Now, there could also be contusion, which actually causes injury to the brain, and also laceration. Now, other classification could be mechanism of injury, which could be either blunt, penetrating injury, open or closed injury, hemorrhagic, which could be either extradural, subdural, or arachnoid or intracerebral. It could also be focal or diffused. Now, other classification can also be can also use the GCS as form of classification in terms of severity, mild, moderate, or severe. Now, depending on for mild, the GCS should be between 13 to 15, moderate 9 to 12, and severe 3 to 8. And then we all know less than 3 is actually brain death. Now, traumatic brain injury. Now, well, basically injury, the head injury we're talking about, we said we talk about the brain injury or traumatic brain injury. Now, primarily, when there's an impact to the brain, which could be either in terms of concussion, contusion, or laceration. This one is outside the covering of the brain. Now we're talking about the brain tissue itself. Now, primarily, there's a traumatic brain injury. We're talking about contusion, concussion, or laceration of the brain. Now, consequences of this, either the contusion, concussion, laceration, can actually lead to secondary traumatic brain injury. These are complications or consequences of the primary brain injury, primary traumatic brain injury. Now, apart from the brain injury, there are other parts of the body that could also be affected. We all know the face, obviously, will be affected. Long bones, vertebral column, the chest, the abdomen. So most times, 50 to 60% actually involves these parts of the body. Now, there's a particular doctrine, a common doctrine, or an important doctrine in head injury, we call the Morrow-Kelly doctrine, which states that now, when head injury occurs, there is actually, because the brain, we all talked about that the brain made up about 2% of total body weight, total body weight, and also blood and also intravascular volume, the CSF volume. Now, the rule is that the brain tissue, like in some textbooks, we say that brain is about, the weight of the brain is at an adult brain is about 1.4 grams. Sorry, 1.4 kilograms actually, or that's 1,400 grams. Then the blood supply, the volume of CSF in the brain is about 50 to 75 mils per gram, and also the blood supply also between 50 to 75 mils per gram of brain tissue. Now, this the amount of brain in the amount of brain tissue, the blood supply, and CSF volume in the brain must be equal. That's what this doctrine is just talking about. Now, whenever there's a distortion in the equilibrium of the brain, the CSF volume, or the blood supply to the brain, that could be from the impact of head injury, that could be raised intracranial pressure, that could be things like raised intracranial pressure. Like when we look at this picture, we find that there's no issue with the brain here. The brain is intact. There is no trauma. There is no mass within the brain. Now, when there's a mass within the brain resulting from head injury, maybe bleeding into the brain, we find that for initially there could be compensation, like in terms of maybe concussion, when there's no trauma to the brain, somehow the brain can actually compensate. There will be no intracranial pressure. Now, when there is moderate to severe head injury, when there is actually formation of mass, either from blood collection into the brain, you find that the equilibrium, there will be no the balance between the brain, the CSF volume, and the blood volume in the brain will be compromised, and then there will be raised intracranial pressure or elevated intracranial pressure. Now, what this is called the graphical representation of the curve. As the raised intracranial pressure, the normal raised intracranial pressure should be around 10 millimeters of mercury, but you can see that it's rising above also about 40. Now, intracranial pressure basically is a pressure within the brain context or within the skull. Now, pressure of the blood flow through the brain itself is referred to as cerebral perfusion pressure. It's important to note. And also the pressure of the blood in the body itself is called the mean arterial pressure. So it's important to note. And also the normal state, like I said earlier, the normal cerebral flow is between 50 mils to like 75 per 100 grams of brain tissue per minute. Now, like I said earlier, the normal intracranial pressure is between 10 millimeters of mercury to 20. When it's above 20 is abnormal. When it's 40, above 40 is actually severe. And that's when we have deterioration in brain function and our report outcome. Now, intracranial pressure itself, and like we said, for you to talk about, we talk about the intracranial pressure, the cerebral perfusion pressure. We can see for us to pick out our cerebral perfusion pressure. We talk about the mean arterial pressure minus the intracranial pressure. This is the normal range, 50 to 150. So now the clinical features of raised intracranial pressure. From the slides, you can see when you get to the patient, to the site of the accident, either the patient dead, or sometimes that could be lucid with no obvious external injury. You see that the patient actually, when you get at the person, you find the person will be conscious with time, the person starts deteriorating. And that could be coma, altered level of consciousness. And then these are actually the symptoms of raised intracranial pressure. We have headache, vomiting, seizures, we have diffusion triad, bradycardia, hypertension, and abnormal respiration. This makes diffusion triad. And when you further examine this patient, pupillary changes, papillary edema, and this patient. Now we're going to go details into the management of head injury, but it does start by an introduction. Now, first of all, when there's an injury to the brain from the site of the injury, maybe from accident site, or from home or industries, before presenting to the hospital, when you get there, because you're going there with your first aid, for example, it's important for you to actually note the mechanism of accident, how it occurred, mode of transportation, history of loss of consciousness, any lucid interval, and general examination. These things are done very quickly as you're taking the patient to the hospital. And in your general examination, you look at the patient's body, look at the vital signs, to also ascertain there's raised intracranial pressure. Now, when patient is hypotensive, is rare actually to find hypotension or tachycardia in isolated head injury. So whenever you see any of this, it's important you look out for the cause of it. It might not actually, most times not actually from the head injury itself. Now we also look at for evidence of basal skull injuries, skull fractures, look at the raccoon sign, the battle sign. Also look out for CSF leak from the nostrils. Other manifestations, like I said earlier, head, nose, headache, nausea, vomiting, seizures are also noted whenever there is raised intracranial pressure. It's also important to assess the level of consciousness of this patient using a stomach scale, which is one of the most important. You know, look at the papillary eye, if you look at the motor, the Bambinski, all this actually tell you if to actually know the patient if it's mild, moderate, or severe head injury the patient might be having. Now, we actually investigate this patient, but before this is done, the patient must have been stabilized, you know, in the hospital before you carry out any form of investigation on this patient. Now, investigating this patient from the slide, we can do full blood count. We want to look at the form of infection, anemia, from the blood loss, you know, electrolyte, urea, and creatinine. You're looking for electrolyte loss, fluid loss, because the patient must have lost a bit of fluid. You look at the random blood sugar. Sorry for this, there's a mistake on the slide. Actually, random blood sugar. Actually, look at if the patient is diabetic, but it also play a role in the management of this patient. Now, other investigations you do are radiological investigations, X-ray. Actually, this is actually obsolete, but it's important of note we talk about it actually when you're in a facility where other advanced radiological machines like CT or the MRI are not available. So actually, this can actually diagnose either as fracture, if there is a pneumocephalus, if there's any foreign body in the brain, you can actually pick out. Now, importantly, one of the basic or the most important radiological investigation is a CT scan. So CT scan, this one from the slide, you can see the absolute indication. Patient is unconscious. When you get the patient is unconscious, altered sense, it's important to do a CT scan for this patient. It's diving towards moderate or severe head injury. Focal neurological deficits, if there's any overt sign of head injury, like panda sign, battle sign, if there is any pop, look at the brain tissue is depressed, it's so important to do, and convulsion also varying from the nose anywhere, so it's very important of note. Now, other indications for CT scan are like I said, neurological deficits, penetrating head injuries, suspected child abuse, alcohol intoxication, worsening headache. These ones are other indications. Actually, when a patient is having mild head injury, or you bring a child that has been having signs, these features, you have to do a CT scan to do that head injury. Now, other form of investigation is the MRI, useful in brainstem injuries, to evaluate the CNS, diffuse axonal injuries, to evaluate posterior fossa structures. Sorry. Okay, now these are the brief. We're going to talk about the intracranial lesions now. We're talking about the when we talk about the mechanism of injury, which could be hemorrhagic. Now we have the epidural, subdural, and intracranial. Now for the slides, you can see from the epidural, the subdural, and intracranial hematomas. Now for the epidural hematoma, there's actually collection of blood clots within the dura and the mater and the bone of the skull. It's actually because the middle meningeal artery, which passes through, covered by the temporal bone. When there's a lesion there or when there's an injury there, it actually bleeds and collects. There's brief loss of consciousness, patient is having headache, drowsiness, nausea, vomiting. We have and patients are deteriorating, and also talk and die. Talk and die actually refers to when sometimes when this patient comes, you see them actually talking. You feel probably it's not a serious issue, and then they start entering into lucid interval and then start deteriorating. If care is not taken for this patient to be properly managed and the blood collection, the bleeding stop, the patient might actually die from there. So that's what the talk and die actually refers to. Now, from here, we can see the picture of the epidural hemorrhage. You can see from the small collection and then the large collection pressing the brain, increasing the pressure in the brain. Now, these are also the pictures, also those pictures. Now we go to subdural hemorrhage. Now, subdural hematomas, which actually results from subdural hemorrhage, is most frequent from tearing of bridging brain between the cerebral cortex and the draining venous sinus, where it's actually classified into three types depending on the timing or duration. Right? The acute, if it's less than 75 hours, actually from the point of injury to presentation, 75 hours, less than 75 hours of acute, 75 hours to 2 weeks, then up to 3 weeks, then chronic, more than 2 weeks. And most of the time there is progressive deterioration in mentation or in mental function of these patients. We have the intracerebral hematomas formed within brain tissue and caused by shearing or tensile force that mechanically stretch and tears deep into the small caliber of arteries. Most common is the temporal and frontal regions. Also affects the clinical feature depends on the site involved. So the patient might start losing function depending on the part of the brain that's actually involved. Now we have the diffuse axonal injury. We just talked briefly about it. Can be actually one of the features is just one of the things that causes is actually shearing force disrupting the axonal fibers in the white matter. Most times shaky baby syndrome, which is most common in pediatric patients. Blunt trauma to the head. Most times there's rapid rise in intracranial pressure, and also there is actually prolonged and permanent. Most times the injury to the brain is actually prolonged and permanent. Now, for the management of a head injury, generally, I used the survey method, primary survey, secondary survey. For the primary survey, it's important because it's an emergency. Not all head injuries are surgical emergencies. So it's important that airway or ABCDE protocol must be observed. Then when the patient comes, remember it's a head injury, it could affect the spine, it could affect any part of the body. We have to make sure the neck, head and neck are protected. Airway maintenance and cervical spine protection using collar neck, using our ambu bag. I use the patient not oxygen and other things, intubating this patient with cervical inline stabilization. Make sure that the patient is breathing to make sure that oxygen gets to the brain. Most of these patients has having respiratory issues. Intubate these patients, still we can use our lidocaine, but it's important to actually use lidocaine to relieve pain in this patient, because like pain or spasms can actually spike intracranial pressures. It's also important to also maintain the pressure, blood pressure of this patient. Maintain the mean arterial pressure at greater than 90 millimeter of mercury is adequate. Make sure that the patient is not anemic, blood volume is normal. For cushion, of course, cushion reflex, which actually results to this are just nervous response to the head injury, which can actually lead to cushion triad, which is the bradycardia, hypertension, and abdominal breathing. So it's so important that the blood pressure is maintained. Like I said before, when the patient presents with hypotension, it's important to look out for probably the patient is bleeding somewhere. You mustn't actually look at the focus on the head. You look at the other part of the body, abdomen, chest. The patient can actually having internal bleeding. So when a patient has hypotension, it's not as a result of injury, as a result of other injuries to other parts of the body. Now, also look at for disabilities. Going to the eye, pupillary changes, irregular shape, constricted, dilated, vision problems. It's important to note. Now, for secondary survey, detailed history. At this point, this patient is actually being stabilized or has been stabilized. So it's important to get detailed history. If the patient cannot talk, the patient is unconscious, whoever is around this patient should be at the point of injury or at the point of head injury should actually be called to question. Detailed history examination from head to toe. So you examine this patient, all systems, all parts of the body should be examined. You do your GCS to ascertain the severity. Detailed neurological examination should also be done. Criteria for admission for this patient, not all patients with head injury are necessarily admitted. Some are just admitted briefly for observation and then discharged, depending. Generally, for mild head injuries, you just observe. Now, criteria for admission, if no CT scan is available, we all know that CT scan basically plays the basic role for us to know actually the severity of head injury in this patient. If there's abnormal CT scan findings, it's important to admit this patient. All penetrating head injuries, if it's a pin that enters the patient's head, should be admitted. All skull fractures, CSF leaks in consciousness, moderate to severe headaches, significant alcohol, drug intoxication, or abdominal injury, the patient should be admitted. I don't know if you can hear me. Hello? Can we hear me?
Yeah. We can continue.
Okay, all right, thank you. All right, now we'll look briefly at
Yes, we can hear you, Pascal.
All right, thank you. Now we'll briefly look at the management of moderate head injury. We all know that mild head injury, most of them will discharge. We just observe and then they go home. So we're looking at basically focus more on moderate to severe head injuries. Now, on an inside examination, and then you do your GCS, on a moderate head injuries between 9 to 13, severe is between 3 to 8. Now, when CT scan is obtained and the admission for observation, then frequent neurological check. When this patient improves, and then discharge and follow up this patient. This patient has mild head injury. Now, when the patient deteriorates, you repeat a CT scan. You also manage for any form of severe. When I go to the next slide, we'll look at the protocol of head injury. So just a brief clinical presentation. Now, for the head injury, we can see here an injured head. You do your GCS is 13 to 15. There's no loss of consciousness. This patient should be discharged. with instructions. Instructions should be, care to the head. If the patient has pain, slight pain in the head, you cannot give cervical and collar neck. You give drugs for this patient. You tell the patient to avoid to. If the patient drives, the patient okay to stop driving for the meantime. Patient should stay at home. You give the patient maybe as a patient to actually stay off work for some time. Now, if you check the CCS between 14 to 15, loss of consciousness less than 5 minutes, no focal deficit, no that thing is found. You do a CT scan. If CT is not available, if CT is unavailable, you observe this patient for about 12 hours. If there's improvement, the patient is normal, more than 12 hours, there's no issue with this patient to discharge. If CT scan is recommended and CT scan done is normal, you can discharge this patient as well. However, if CT scan is abnormal, there's features of fracture, contusion, subarachnoid hemorrhage, hematoma, any form of injury to the severe abnormal injury to the brain, the patient should be admitted. Now, for moderate head injury, there's loss of consciousness greater than 5 minutes. There's focal deficit. CT scan is mandatory, even if the patient is there's just plates. The patient should actually be sent for CT scan, which is stabilized. If CT scan is normal, you admit the patient and then observe the patient for more than 12 hours. Patient recovers, you discharge. However, it's important to know that we invite the neurosurgeons in this case, in any case of head injury, actually moderate to severe. You refer to them for them to continue management. Now, for management of severe head injury, which is a GCS of 3 to 8, like we talk about the survey, primary survey, you study this patient, make sure the ABCDE of this patient is okay. Secondary survey is obtained with detailed history. Admit the patient into the facility, neurological care, basically into the ICU. You evaluate this patient's eye-opening motor response, verbal response, eye reaction. All these are very important for you to know if the patient is actually making progress or not. CT scan only for hemodynamic stabilization. With patients, there's medical therapy for raising intracranial pressure, whatever thing you see the patient, you manage. Immediate neurosurgeon opinion, like I said, all patients with moderate to severe head injury should be referred. If there is no neurosurgery patient in that area, you can invite one to actually seek for the patient's opinion. If there's surgical intervention needed, you offer such. Patient must be intubated. Patient with moderate to severe head injury, respiratory issues, with intracranial pressure, please, the patient must be intubated. Should be managed in ICU. It's not in the ward, please. ICU management. Now, we have a management of head injury depending on whatever the patient presents, or from the clinical features or laboratory features, we have medical and surgical management or interventions. From the list here, we can see brief list head up should be about 30 degrees. IV fluids, hyperventilation, monitor, furosemide, steroids. However, steroids have been noted to be, play little or no role in the management of head injury. Barbiturate, anticonvulsant, all these are needed in the management of head injury or an injured patient. Like I said, the patient must be managed in ICU. See little pictures of oxygen must be there. All right, for the medical therapies, like I said, the patient must be managed head up, head injury, elevate the head, intravenous fluids to maintain normal volemia, hypotonic glucose containing fluids should be recommended in acute phase, please. Only in acute phase. Patient electrolytes, serum sodium must be monitored daily. Now, for the mannitol, which is a osmotic diuretic, this is the dose required. The osmotic agent basically to reduce rate in intracranial pressure, maintain cerebral blood flow, the cerebral perfusion pressure, and brain metabolism. This is one of the reasons why we use mannitol. Action starts between 5-15 minutes. So most times you don't expect the action to start early enough and peaks around 90 minutes. So you must have done other interventions before the monitor actually picks up. Other functions of this is to reduce the viscosity of blood, reduce CSF production, free radical scavengers. You pick up free radical because of the acuteness of injury, beneficial effects on cardiac function as well, diuretic effects, and then for the food, you can also use furosemide to reduce, also in conjunction with mannitol. This is the dose It's just all right. Now for hyperventilation, now this is not actually always used, so it's not used for prophylactic case unless if needed, please, for you to hyperventilate this patient. So just for temporary measures only, actually does what it does is just to drive out the CO2 from the patient and also reduce the brain, the correction of fluid in the brain, whether by reducing the intracranial pressure. Now for barbiturates also effective in reducing intracranial pressure, and then not used in presence of hypotension and hypovolemia. Please, the patient must make sure that the patient's blood pressure is adequate, pulse rate is adequate, blood level is adequate, before use barbiturates. Anticonvulsant phenytoins of drug of choice, loading dose this, maintenance dose is this. The patient is having convulsion. Now for IV fluids, actually most time the patient will be dehydrated. There is no room for use of hypotonic fluids, please, so that they won't drive in water into the brain, because you're trying to avoid fluid collection into the brain. So hypotonic fluid are not used. Use of glucose-containing fluid can result to hyperglycemia. So most times we don't use glucose-containing fluid. Most times we recommend normal saline gas lactates, for the patient, unless if highly indicated in this patient. Hyperventilation, like I said earlier, should be used cautiously. This adds by reducing, like I said earlier, the CO2, cerebral vasoconstriction, and generally it's preferable to keep the PCO2 at 30 millimeters of mercury or above. Now for anticonvulsants, convulsion actually occurs in 5% of all patients admitted in hospital with closed head injury. 50% of those with severe head injury. Those with increased risk are those with GCS of less than 11, early post-traumatic seizures, penetrating head injuries. So these are people who are actually most at risk, who actually need these anticonvulsants. Like I said, steroids to date do not have demonstrable and beneficial effects in controlling raised intracranial pressure or improving outcome of head injury. Therefore, steroids are not recommended in management of traumatic brain injuries in our environment. Now, the surgical aspect of this, there's an injury to the scalp, to the brain, to the scalp, to the brain, or the head. Scalp injury, you clean and debride, elevation of depressed fractures, surgical intervention like the craniotomy, evacuation of hematoma, can do the borehole, cranial decompression to reduce intracranial pressure. Look at the borehole. This is actually for the surgical people. Yes, operative measures. We have the skin incision, craniotomy. These are some of the equipment used. Now, prognostic factors all depends on one, GCS of this patient. The patient, the worse the GCS, the worse the prognosis. The better the GCS, the better the prognosis. Young patients generally do better, unlike elderly patients. Focal brain injuries do better than diffuse. Extradural hematomas better than subdural. Bilateral reactive pupillae better than bilateral unreactive. Localization of pain. Patient who can localize pain actually does better than patient who does not or who do not. Now, this is the staircase, what we call the staircase protocol. I would have said it when we're talking about the raised intracranial pressure, but I just put it towards the last slide. And for us, this is the ascending protocol of management of raised intracranial pressure. Depending on the patient, if the patient does not respond, as we keep going up, and the patient does not respond until you get to the end. It's just what this staircase protocol for management of raised intracranial pressure. Now, what are the complications of head injury? One, seizures. You find that the patient will come to clinic, you find that the patient who had head injury 10 years ago, 15 years ago, you see them having from that time start having seizures, which will actually get worse. So this patient can come down with hydrocephalus, encephalopathy, psychiatric problems, permanent neurological defects, post-traumatic amnesia. So these are some of the long-term complications of head injury. Now, it's important to also care for other parts of the body or other systems of the body. When the patient is injured, the eye, most of the eyes are affected, the bladder, the bowels, the limbs, the nutrition is also important. occupational rehabilitation, physiotherapy is much more important in this patient, especially on post-hospital care. They should be followed up. Most of them can come down with neurological deficits. It could be a long-term requirement for physiotherapy. Now, outcome, like I said earlier, for common scale outcome, death is only 1, vegetable state is 2, severe disability is 3, mild disability is 4, good recovery is 5. So when the patient from the actually the outcome and the progress of the patient could be better or not. Now, prevention of head injury is very much important for us because we all know that is one of the leading causes of death in our environment, actually the second leading cause of death in Nigeria. Safer roads, we can advocate for our government to make our roads safer, have good roads, without potholes, if it's possible. I don't know when that was possible. Enforcement of law guiding the rules of the roads. So many people who drive actually do not know how to drive, do not know the rudiments of driving. So people don't drive anyhow and cause accidents. Advocates of helmets, seat belts, airbags, gun control legislations, improved pre-hospital care. There should be ambulances. There should be air ambulances, especially. We should advocate for that. There should be air ambulances in Nigeria whenever there is head injury somewhere along Kogi State, where we don't have any traumatic facility along the road. Helicopters can go there and pick the patient and bring the patient to Gariki Hospital, where we can manage. And then conclusion, endotracheal intubation is very much important for these patients. Moderate hyperventilation, treat shock aggressively. Whenever the patient is losing blood or is going into shock, you treat aggressively because this actually better the prognosis of these patients. Resuscitate with normal saline and Rengas lactates. The goal is to achieve hypovolemia states. Now, head injured patients need not to die in the site of accident if all things are done well. Head injured patients should be carefully assessed in order to categorize them, differentiate them if they're actually mild, moderate, or severe. The more severely injured should be stabilized and referred as soon as possible. Multidisciplinary approach is key to the management of head injured patients. As we all know, improved medical facilities coupled with skilled first contact physicians and appropriate public awareness will improve prognosis. Now we can imagine the Okada rider. So these are the problems we have in our environment, where we say people should wear helmets, they don't wear. Look at what this man is wearing. You can see, I want to get all the money. So you see somebody carrying 6 children with him himself. All right, so these are my references. I try to make it as brief as possible because the presentation was actually given to me when I was on leave, enjoying myself. So I just had a few days to carry out this research and everything. Thank you very much.
Well, thank you very much, Dr. Pascal, for the presentation. Well done. Can you hear me?
Yes, Chief, I can.
Hello.
I can hear you, but
me?
Yes, I can hear you, but it's starting.
So thank you for the presentation. So, okay, so we'll be taking questions and contributions now. First from the medical officers and the junior residents. Questions and contributions, please. It's almost 9 p.m.
IJ, there's a question on the chat.
Okay, there's actually a question on the chat window. Maybe I'll take that first. Yes, from Dr. Nafiu. She said, Dr. Pascal, can you hear me? And also for the residents, what is the role of the family physician in the management of head injury using the 6 or 7-star doctor, levels of prevention as well as on the residents? resident in the management of patients with head injury.
Good evening, everyone. The role of family
Good evening.
mediation in the management of health injured patients. Dr. Pascal already mentioned part of advocacy and advocating for proper helmet wearing when you're on a motorcycle. But starting from the first caregiver, we should be able to identify easily the severe injured one, the severe injured head patient, so that we're able to treat them fast and also be able to manage resources. Also, we should be able to research more on how to treat better or how to treat our patients better. And also community leader in an environment where we can advocate for how people are on the motorcycle, we'll be able to lead the community in such a way that we can advocate more for the proper equipment or proper awareness, how they're supposed to wear helmets, and how they're supposed to themselves on the motorcycle. And then also my communicator and coordinator, we should also be able to do that. What other questions? And the level of prevention as well as the family medicine too. We should also be able to prevent the incident. Also, like Dr. Pascal mentioned, in a case where family had 6 children on one motorcycle, that should be avoided. We should be able to explain to them that they should be able to subdivide them into separate motorcycles, and also explain to them the significance of actually having, like example, having a breadwinner that has injury to the head is going to affect not only the wife, the children, it's going to affect the family function of that family after. And also we could use, like you said, it's more common in man, patients. We should also be able to use home visits to check if it's a common thing in their family. Maybe the father is the gang or the motorcycle club. That kind of patient, the son is easily going to get head injury because they're really seeing his father. So we as a family physician, using our family medicine tool, we can also be able to easily identify the patients that can have head injury or not have head injury, and also advise them not to have head injury. But any other resident?
Okay, thank you very much, Dr. Abinde. Does any other resident have anything to add on the role of family physician? Please, let's be fast. It's almost 9. Okay, there are still other questions. Dr. Otokwa is asking, she said, what is lucid interval in the evaluation of head injured patients? Can you hear me? What is lucid interval in the evaluation of head injured patients? Dr. Pascal, do you have the answer to this question? You mentioned it in one of your slides.
Hello, can you hear me?
Yes, we can.
Lucid interval is actually a temporary improvement in patient's condition with traumatic brain injury, after which you find this patient will start deteriorating. That's actually what lucid interval refers to. So most times you find this in patients with epidural hemorrhage, you know. So in fact, other form of traumatic brain injuries. So you find this in those patients. Can we hear me? Can we hear
Yes,
me?
we can.
Yeah.
We can hear you, sir.
Okay, I just said what I just answered the question. Hello.
Hello, yes, Pascal, we can hear you. Can you hear me? Someone wanted to say something and was
Yeah,
cut off.
I think I don't know what happened. My Zoom just went off. I don't know if it happened to the other person. I just came on again.
Okay, does anyone have any other thing to add? I think he was right in the way he answered it. The question about lucid interval being the temporary improvement in the patient's condition after traumatic brain injury, and then subsequently the patient's condition now spirals downwards. He deteriorates. Okay. So she also asked for residents and for exam purposes, note the difference between head injury and traumatic brain injury. It was differentiated, but later the presenter kept on using it interchangeably. Dr. Pascal, can you tell us the difference between the two?
Hello?
Yes, can you hear me?
Yes, Chief. Can you hear me?
Yes, we can.
Yeah, head injury.
Can we all
Like
hear him? No one is saying anything.
head injury. We all know
I'm hearing you.
is an impact or is a traumatic impact to the head. Not necessarily the brain might not be injured in the case of concussion, you know. But in traumatic brain injury, the brain is actually affected, and that's when you start having signs of raised intracranial pressure, lacerations, hematomas. So these are whenever the brain is the head is affected, is traumatized, but the brain is intact. It can be said the patient has a traumatic brain injury. So the traumatic brain injured patient, most of them come down with moderate to severe symptoms or complications. That's my own understanding for it.
Hi, so Pascal.
Hello? Hello, can we hear me?
Yeah.
Hello? Hello?
Okay, hello, can you hear me? I
Yes,
was
Chief, can you hear me?
disconnected.
Can we hear me?
Hello.
Yeah, I can hear you.
Okay. I think Dr. Ichado is trying to say something. Miss Chief, are you trying to say something? The network is quite poor. Okay, I was disconnected. momentarily. So Pascal, please, can you look at the chat window? Are there more questions there?
I can't. I'm not. I can't see any question. I can't see any question.
Okay. Please, any further questions or contributions? Does anyone have anything to add or to subtract? Okay, in the absence of any other thing, I think we can call it a night. It's already past 9. So thank you everyone for tuning in. We'll continue next week by God's grace. So good night, everyone.
Good night.